So, good evening, esteemed guests. I'm Dr. Shuichiro Shina, the president of APASL, Asia and Pacific Association for the Study of the Liver. We extend a warm welcome to each of you as we embark insightful journey of the ALCAP program. This evening, we dove into the third installment of the ALCAP series, commencing with session 1 focusing on systemic therapy for hepatocellular carcinoma. Throughout this program, our goal is to impart a comprehensive understanding on nuanced management strategy of advanced hepatocellular carcinoma. I encourage you to immerse yourself into the wealth of knowledge and expertise that will be shared during the session. So let our exploration begin.
Thank you very much, Professor Sheena, President APASL, and also a very warm welcome to our own Professor Masao Omata, who has also joined luckily today. Other senior colleagues, on part of the steering committee of the APASL, would like to say that this year we have a very strong program on liver cancers. They are led by Dr. Sheena, the president himself, Dr. Omata, and ALCAP. And the conference, the annual conference of APASL is in Kyoto on 27th to 31st of March. We invite you to join, and there is a full day of HCC. Today we are privileged in the third session to have two of the best experts, Professor Fabio Piscaglia and Professor to give us excellent talks. I would like also to thank our coordinator, Dr. Ashok, for inviting them, and to our own Dr. Muthaiya for taking the care on clinical grand rounds today. Welcome to all of you. And since Dr. Fabio has not joined, maybe we can start with the first talk by Dr. Huang. Is that all right, Dr. Huang, for you?
Okay, no problem. Yes.
Yes.
Thank you.
Most welcome. Professor Huang is the Chief of the Division of Gastroenterology and Hepatology, Department of Medicine, Taipei, Veterans General Hospital, Taipei, Taiwan, and Institute of Clinical Medicine, National Yang Ming Chiao Tung University School of Medicine, Taipei, Taiwan. He is an expert in the field of liver cancer and would tell us about the mechanism and rationale for immunotherapy in HCC first line, and upon failure of TKI, an algorithm for resource-limited countries. A very important topic. We are looking forward, Professor Huang, for your kind lecture. Welcome.
Okay, thank you, Professor Seding, for your kind introduction. So, would you please, Ms. Izumi, place my pre-recorded video. Thanks to the organizing committee for inviting me to participate in this APASL ALCAP program. I'm Yixiang Huang from Taipei Veterans General Hospital and also the president of Taiwan Liver Cancer Association. My topic today is mechanism and the rationale for immunotherapy in HCC, first line and upon failure of TKI, algorithm for resource-limited countries. Liver cancer are prevalent in Asia-Pacific region and ranks the fourth most common cause of cancer deaths worldwide. Immune checkpoint inhibitor by blocking PD-1/PD-L1 axis and CTLA-4 that could restore anti-tumor immunity is now the key treatment for many cancers, including HCC. Bevacizumab is an anti-angiogenic agent with additional immune modulatory effect by reversing VEGF-mediated immunosuppression, including promote DC maturation, normalization of tumor vasculature, increasing T-cell infiltrate, and decrease the activity of MDSC and Tregs. IO combination by blocking suppressive T-cell signaling in the lymph node through CTLA-4 and suppressing PD-1/PD-L1 interaction in the tumor microenvironment also showed promising results in Himalaya studies. The most attractive point for the immunotherapy is that immunotherapy offers potential for durable tumor control. Both APASL-150 and the STRIDE regimen demonstrate the long tail of overall survival. This means that a certain portion of a patient with advanced HCC can enjoy long-term survival through immunotherapy. However, compared with other cancer types, HCC has a relatively high proportion of non-T-cell inflamed tumors, indicating that HCC could be classified as an immune cold tumor. Therefore, only 20 to 30% of HCC patients achieve objective response with APASL or STRIDE regimen in phase 3 clinical trials. Due to the success of APASL-150 and the Himalaya clinical trials, EASL and the BCLC endorsed APASL and tremidurba as the first-line systemic treatment for HCC in patients without contraindications. Recently, the AASLD provided similar advice. The STRIDE regimen is favorable for HCC patients at high risk of GI bleedings. Apart from APASL and tremidurba, biosimilar atezolizumab and bevacizumab and Camrebo also showed their superiority to sorafenib in phase 3 clinical trials. In Taiwan, APASL has only been reimbursed by National Health Insurance since August this year. I will talk about the efficacy of immunotherapy for HCC in real world. I will show you some real world data. This is a large cohort real world study by including patients from Asia, North America, and Europe. In Asia, also enrolled our patient, and this study population is over 200. And interestingly, this data show that for patients with CHOP-A undergoing APASL treatment, the median overall survival was around 16.8, and for CHOP-B patient was around 6.7. Regarding the response rate, in overall patient, 25%, for CHOP-A patient, 26%, for CHOP-B patient, 21%. For disease control rate, for overall patient, 17.3%, for CHOP-A patient, 17.4%, for CHOP-B patient, 6.68%. And regarding the complete response rate, in this cohort was around 1%. So in general, the data is quite similar to the APASL-150. Another real-world cohort incorporated more patients from Korea, and this international consortium expanded the patient number for nearly 300. And in this real-world cohort, the median overall survival by APASL was nearly 16, and the progression-free survival was around 6.9. By comparison, the ALCAP with the AMBRE 150, both the overall survival and the progression-free survival were quite similar for the both lines. Even though the APASL is now one of the standard care for advanced HCC, but some real-world data suggests that the overall survival of the APASL was quite similar to the lenvatinib. In this real-world data, by enrolling over 800 patients receiving the APASL and over 1,300 patients receiving lenvatinib, the overall survival was similar between the two treatment arms, and the p-value was not significantly different after the IPTW adjustment. The author further divided the HCC patient into the viral etiology versus NASH novelty etiology. In your left-hand side is the HCC with the viral etiology, and you can see the KM plot. The APASL provides a better overall survival as compared with the lenvatinib with a significant p-value. However, in your right-hand side is the NASH HCC. On the contrary, in this subgroup patient, APASL did not provide a better overall survival, which was inferior to the lenvatinib monotherapy. So this data suggests that etiology of HCC could be considered by choosing the treatment strategy. This Nature paper suggests that NASH may limit anti-tumor surveillance in immunotherapy-treated HCC. Therefore, for NASH HCC, the tumor microenvironment may not be feasible for the anti-PD-1 treatment. So this finding may echo some real-world data suggesting that non-viral HCC, lenvatinib shows a better OS as compared with the APASL. Currently, there are several real-world data by comparing the APASL versus lenvatinib monotherapy, and interestingly, these findings suggest that the overall survival seems similar between the lenvatinib versus APASL, and the objective response rate for the lenvatinib was around 30 to 50, and for the APASL was around 30 to 40, which was also showed quite similar. And this is the example of Japanese real-world data by comparing 66 patients receiving APASL and the same patient received the lenvatinib after propensity score matching. Even though the overall survival and the progression-free survival were similar between the two treatments, however, regarding the liver function reserved, APASL performs better than lenvatinib monotherapy in terms of OB-grade migration or the OB-grade modified OB-grade migration. In our daily practice, it would be helpful to have a biomarker to select which patient can respond to IO and which patient should treat with the TKI. However, so far there is limited data regarding the biomarker for HCC. As mentioned, about 20 to 30% of HCC were immune-exclusive subtype, which were primarily resistant to immune checkpoint inhibitor. For those patients, maybe have a CTNB1 mutation, result in Wnt beta-catenin signaling activation, and those patients were poor responder to immune checkpoint inhibitors. One study from Europe proposed a so-called gravity score by incorporation of a CRP and AP level. For patients with a high AP level, 100 nanogram per ml, and CRP level higher than 1 milligram per deciliter, those patients would be poor overall survival by immune checkpoint inhibitor. And for patients with low CRP and low alpha beta protein, those patients could have a longer survival by immune checkpoint inhibitor, indicating that for patients with low CRP, low alpha beta protein, we should provide those patients more aggressive treatment to prolong their survival. Is there any molecular-based biomarker that can predict the response to the APASL? This study published in Nature Medicine. The author, by using the transcriptome analysis, genetic profiling, and in situ immunohistostaining, and find that certain molecular marker and the gene signature can correlate with the response to the APASL. In this study, the authors identified 10 candidate genes and incorporate them as the so-called APASL response signature, abbreviated as the ABRS. For those patients with a high ABRS score, then those patients will have a better progression-free survival and overall survival by APASL instead of sorafenib. And the other potential marker including the high PD-L1 level and the high effector T-cell population. So these data suggest as potentially biomarker that can predict the response to the APASL. Gut microbiota is considered to be able to modulate the outcome of certain cancers to immunotherapy. In these two science papers, suggests that gut microbiota can modulate response to anti-PD-1 immunotherapy in melanoma and also in lung cancers. We'll study the role of gut microbiota on HCC immunotherapy. We collect the patient feces and blood samples, and the fecal samples were analyzed for microbiota and metabolite. Then we developed a fecal signature predicting the treatment response. We also collect a validation cohort, consecuted triple A patient, ICI treatment naive patient were investigated for validation of the signature. And the patient who used lactulose, PPI, NSAID, antibiotic, probiotic, prebiotic, or also within 4 weeks prior to the immunotherapy were excluded. Therefore, we enrolled the 21 responder and the 21 non-responder for first-step comparison. And interestingly, we found that the gut microbiota were different between the two groups. By comparison, the responder and the progressor, we found that the Probotella 9 is associated with the tumor progression, and the 3 species bacteria were associated with the tumor response, including the lactoclostridians. And we further compared the difference between the metabolite. We found that the secondary bile acid, including the UDCA, UCA, and MDCA, were significantly higher in patients with tumor response. And those metabolites are highly associated with the gut species. We further enrolled 33 HCC patients undergoing immunotherapy as a validation cohort. In this cohort patient, we found that for patients with good gut microbiome signature was associated with higher tumor response. And for patients with poor gut microbiome signature, all were progressors. And for patients with enriched in Probotella 9 were associated with poor progression survival and poor overall survival. And for patients enriched with lactoclostridian were associated with longer progression-free survival and longer overall survival. In general, for patients with preferable gut microbiome signature will associate with better progression-free survival and overall survival. So our finding suggests that gut microbiota is a promising biomarker for HCC immunotherapy. Next, I will talk about the effect of TKI exposure on immunotherapy, as we will talk about the TKI failure and the role of the immunotherapy. This table shows the target profile of the TKI and the monoclonal antibody for the treatment of GCC. In general, all the TKI targeting on the VEGFR1 to R3 and also the PDGFR and the c-KIT. And for the monoclonal antibody, targeting for the VEGFR1, 2, 3, and for REMO, targeting for VEGFR2. So in general, VEGFR is the common target site for the current TKI and the monoclonal antibody against the HCC. So how about the tumor microenvironment after exposure to the TKI? This study showed that the lenvatinib could reduce the tumor PD-L1 level and the Treg differentiation, consequently to improve the anti-TD1 efficacy by blocking the FGFR2 pathway. So this data suggests that after lenvatinib treatment, immunotherapy by the anti-PD-1 or anti-PD-L1 is a good choice. And this data shows that the immunotherapy after exposure to the lenvatinib, most of the patients can respond to the immunotherapy. And this study enrolled a patient from baseline, then exposure to the lenvatinib treatment, and after that receiving the surgical resection. So they compared the sample before and after lenvatinib treatment. Interestingly, they found that after the lenvatinib treatment, the CD8 T cell population would significantly increase. So this data suggests that lenvatinib treated patient can increase the CD8 T cell population in human sample. So as well as the cytotoxic granzyme secretion CD8 T cell, indicating that lenvatinib followed by the immune checkpoint inhibitor may be a promising sequencing to improve the response to the IO. How should sequential treatment be considered after TKI, especially by first-line lenvatinib? And this data suggests that immunotherapy after failed by prior TKI, and the median overall survival was still not reached in this real-world data. So this data suggests that TKI followed by the IO may be considered. There are expert recommendations from Hong Kong, Singapore, and Taiwan, which has been published on Liver Cancer 2022. In this recommendation also suggests that after first-line TKI, IO can be considered as the second line. The choice of therapy in the second-line setting depends on several issues, including mode of action, safety, tolerability, efficacy, and the cost, as well as the response to the first-line therapy. So the patient's liver function, reserve, tumor burden, performance status, and the quality of life is also important. So in this statement, an IO-based regimen can be considered as a second-line treatment option following first-line TKI because of its alternative mode of action. So all the experts agree such a statement. Current international guidelines suggest immunotherapy, including the atezo-beva and the tremelimumab regimen, should be the first-line systemic therapy for unresectable HCC. However, currently the price of the immunotherapy is still high, and which may not be suitable for patients living in resource-limited countries. Therefore, for patients could not afford IO, another algorithm may be considered. Let's look at the two interesting and important clinical trials by using the biosimilar immune checkpoint inhibitor. In your left-hand side is using the biosimilar anti-PD-1 camrelizumab plus a TKI called the rivoceranib. And this study, by comparison with the sorafenib, showed a superiority in progression-free survival 5.6 versus 3.7 by sorafenib, and also in overall survival by camrivo 22 months versus sorafenib 15. So this study suggests that biosimilar IO can be combined with the current TKI, which can show a survival benefit as compared with the current TKI monotherapy. And your right-hand side is interesting design by using the biosimilar anti-PD-1 sintilimab plus the biosimilar bevacizumab. And this study is similar to the UNBRAVE 50, and by using the biosimilar combination, this study also showed a superiority in progression-free survival 4.6 versus 2.8 by sorafenib, and also superiority in overall survival non-reached by the biosimilar IO combination versus 10.4 by sorafenib alone. So these two studies suggest that biosimilar immune checkpoint inhibitor may be feasible for patients living in resource-limited countries. The recent ALCD pricing guideline regarding the treatment strategy for HCC with systemic therapy consider the immunotherapy as the first-line treatment if the patient did not have any contraindication for immunotherapy, such as autoimmune disorder or history of liver transplantation. And for patients with high risk of GI bleeding, Tremi-Durva is the first choice. And for patients did not have a risk of GI bleeding, Atazolbeva or Tremi-Durva could be considered. However, for TKI, including the sorafenib or lemapimod, now move to the second line after the IO treatment. But sorafenib and lemapimod can be used as the first line if the patient has a contraindication for immunotherapy. This algorithm may not be feasible for every country, especially for patients in resource-limited countries, because currently the IO price is still high. In those countries, I consider the biosimilar immune checkpoint inhibitor is an option. By using the biosimilar ICI or biosimilar anti-VEGF or biosimilar ICI plus the TKI, or another choice is the lenvatinib monotherapy, because current real-world data suggests that lenvatinib monotherapy may have a very similar overall survival as compared with the Atazolbeva. In conclusion, ladies and gentlemen, IO combination therapy has become the first-line standard care for advanced HCC if there are no contraindications. For patient selection, currently the biomarker-driven IO therapy has not yet been implemented in our daily practice. Several real-world data shows similar in overall survival between the Atazolbeva and the lenvatinib, but better liver function result was observed by the Atazolbeva treatment. And the TKI followed by the immunotherapy is mechanistically feasible. For countries with limited resources, biosimilar IO plus the biosimilar bevacizumab or biosimilar IO plus the generic TKI may be considered. Thanks for your attention.
Very nice, Professor Huang. It was so clear and very educative for us. May we have some questions, and I am privileged that Professor George Lau, who is also one of the lead authors and workers in the durvalumab study. Can we have some comments from Professor Lau before others?
It's really a very nice lecture by Professor Wang. And it is interesting that biomarkers is being attempted for the I'm Brave 150 APASL beaver. My question is, you mentioned about a gut microbiota could affect the response of APASL beaver, which is very interesting, especially when you have Prevola 9 versus the Clostridium, which will predict more of disease progression. So have you ever attempted to change the microbiota to improve the outcome of these patients? And what is the mechanism behind this? What is your thoughts?
Thank you, Professor Lau, for your very interesting question. So actually, many more and more data suggests that gut microbiota is highly associated with the response to the immune checkpoint inhibitor. Just recently, I read a paper from the Nature Medicine, also, but it's for the melanoma. In that study design, they used the FMT prior the immunotherapy. After the 2 times of FMT, they used the immunotherapy for the melanoma, and they found that almost the waterfall plot, so almost nearly 80% of patients can respond to the immunotherapy. So this is a very pioneer study using in other cancer type. So I just think about our HCC, because so far we don't have many practical, clinically useful biomarker to select which patient can respond to the immunotherapy. So if we can change our patient's gut microbiota, either by probiotic or either by the FMT, so maybe a promising way to make more patients who can respond to the immunotherapy in the future.
It's a very excellent attempt. Congratulations.
Thank you.
You have mentioned Lecnospiraceae Clostridium as the species which is beneficial. Maybe we should feed our patients with Lecnospiraceae.
Right.
I have two brief comments, Professor, and which I personally feel a problem. You start drugs like a combination of atezolizumab and bevacizumab. And how often would you like to keep on doing the CT scans or a MRI or a PET-CT if the patient has a normal or declining alpha-fetoprotein? Would you repeat it? AFP and PIVCA are going down. So would you still do a CT or a PET-CT?
Okay, so it's a very clinically useful question. So for patient undergoing atezolizumab, then have a alpha-fetoprotein level going down, and in that way, I may feel more comfortable. So maybe I will arrange the CT or MRI scan every maybe 8 to 9 weeks. So after the first immunotherapy. So if the image tells us that the tumor has a response or even in stable disease, I can keep the immunotherapy for those patients. But if during the immunotherapy, I found the alpha-fetoprotein level or the PICA2 going high, and in that way, I will perform the CT scan maybe 6 weeks, because in that way, I suppose those tumor may not be very good response to the immune checkpoint inhibitor. So maybe I will change my strategy to treat those patients. So it depends on the tumor response, because in previous studies show that the alpha-fetoprotein protein response, especially early alpha-protein response, has some correlation with the tumor response to the IO.
The second question is, if the patient is on lenvatinib, which is also VEGFR inhibitor, and the patient is progressing on lenvatinib, would you still consider atezolizumab as and bevacizumab combination, or you will straight away go to durvalumab or some other combination?
Okay, yes, this is also very important, especially some of our patients use the lenvatinib in the past few years. Then after progression, so should we can we use the atezolizumab as the second line? Actually, there is no clinical trial to answer this question. But in real world data suggests that even we use the atezolizumab as the second line, the tumor response rate was quite similar to the first line. But actually, the response rate will slightly lower than the first line setting. But currently, some real world data support such a strategy. But we need to collect more prospective data, and it would be better to have some clinical trial to answer this issue.
Thank you. I do not see Professor Fabio. Ashok, has Professor Fabio joined or not? And can you connect with him? We may like to have some.
I think I could not able to connect him because I called him also in WhatsApp. He's not picking. So I think we can go to the.
No, he sent a
Professor
video.
Omata or Dr. Diana also is there. Any comments? Masao?
Excuse me, Professor Fabio sent a video, so may we show that?
Ah, okay, show the video.
Thank you, sir.
Dr. Omata is saying something. You are mute, Masao. You have to unmute.
Wonderful talk. I enjoyed the talk very much, especially the part, the limited resources countries. And then it's amazing that the Lancet Oncology or Lancet put the data by using the drugs such as biosimilar or generics in old days, never be published in the top-notch journals using the generics. So I think time has come, especially in the Asian country. It's one of the key data because we are resources, some of the countries are limited, but that journals provide the information for that. So maybe, how do you see the future, like Taiwan or maybe in Japan, that without definite comparison between the biosimilars, are you recommending to use that?
Yes, it's a very interesting question by Professor Omata. But I believe that Japan is not a resource-limited country. So, but the current data suggests that some. But current data show that biosimilar immune checkpoint seems has a quite similar response as the our standard immune checkpoint inhibitor. But maybe for some patient could not afford or could not fulfill the regulation from the national health insurance, that would be a good choice because for those patients, they always or never has a chance to use the immune checkpoint inhibitor.
Or maybe APASL Kyoto should have a special sessions, to deal with the generics and then to deal with biosimilar in the Asian country. How do you think? It's a special sessions, very unique to APASL. Wonderful talk. I enjoy very much. Thank you.
Yeah, thank you.
Thank you very much. I would like now to hand over to, maybe we don't have, maybe George can, or Dr. Mata can chair the next, moderate the next session by Dr. Fabio, and then Ashok can handle the grand rounds. So I would request maybe Dr. Omata to have the next session, and then
Who is coming? I'm sorry.
it's a video by Dr. Fabio.
He's not here?
No, he sent his video.
Oh, okay. But, so he sent a video. So Izumi gonna run video.
Izumi.
Okay. Please, Izumi-san.
はい。
Dear Madam, dear sirs, we are going now to present the current status of treatment of hepatocellular carcinoma with tyrosine kinase inhibitor. In the year 2002, almost 20 years ago, this was the status of different investigations. Systemic chemotherapy, hormone therapy showed no efficacy in the treatment of advanced hepatocellular carcinoma. These drugs were tested but had limited objective response, severe adverse events, and showed no survival benefit. And indeed, the first international guidelines about the management of hepatocellular carcinoma released by the European Association for the Study of the Liver in 2001 confirmed that none of the available options offer an unequivocal survival benefit to patients with intermediate advanced hepatocellular carcinoma, and therefore recommended multicenter randomized trials. The status at that time was of different molecules to be investigated, many of which were tyrosine kinase inhibitor. Others were monoclonal antibodies, mTOR inhibitors, and others that had different effects on various pathways. The first TKI trial to be released were the ones about sorafenib, a tyrosine kinase inhibitor with different mode of action. And these were one run in the Western countries, which was the SHARP trial, randomized 1-to-1 versus placebo, since at that time that was the reference standard, there were no better options. And the other was run in Asia Pacific, randomized 2-to-1, with the same dosages of the drug. This was the first successful trial showing an improvement in median overall survival. As you can see here on the left-hand side, there was an hazard ratio of 0.69, which was highly statistically significant and brought the survival of patients treated with sorafenib from 7.9 months of placebo to 10.7 months, which correspond to a gain in survival of 35%. And this was due to a slowdown of the radiological progression. There were not many objective responses, but for sure there was a delay in the progression, which translated into the benefit. Almost identical results in terms of hazard ratio were shown also in Asia-Pacific patients. As you can see here, the hazard ratio was 0.68, despite the population had a worse overall prognosis, both for patients treated with placebo and with sorafenib, but again with an advantage in survival for patients treated with sorafenib. Therefore, the benefit of and efficacy of sorafenib was clearly demonstrated and confirmed. Is this the ultimate success that we can achieve with the sorafenib, that of 10.7 months? No, this is not the best, and this has to do with the learning curve. It was the first drug that we were using with the patient with hepatocellular carcinoma. We were still sticking to the recommendation and prescription for dose adjustment and suspension and stopping treatments. But after some years of learning, we could show that even before the arrival of effective second-line treatments, as you can see, the survival, follow-up was stopped in 2017. We could demonstrate in our center that patients treated in the first 5 years, 2008 to 2012, compared with patients treated in the subsequent 5 years, they had a longer survival for patients in the second period. This was due to an advantage in the treatment modality, because patients were treated for a longer period, but with the lower daily average doses, because we became expert in managing the drug and adopting the dosages, avoiding prolonged suspensions, but simply reducing the doses. And this translated into an overall higher exposure to the drug, translating into longer survival. So probably 35% is not the ultimate gain achievable by sorafenib, but this is longer. And this was demonstrated by several trials, which year by year demonstrated in an improvement in survival of patients treated with sorafenib. These were all control arms of other trials in which the control arm was treated with sorafenib. And as you can see, there is a clear trend towards an improvement in survival due to a better management of adverse events and more experienced doctors managing these patients. Therefore, TKI and sorafenib must be held to provide a better efficacy than initially demonstrated. Which is the cost of this survival benefit? Which are the adverse events? There are a number of them, but here you can see the sharp trial, the comparison of placebo here on these columns on the right-hand side with sorafenib, and you can see that if we consider any grade adverse events, most of those listed here were more common with sorafenib than with placebo. Among them, you can count alopecia, dry skin, hand-foot skin reaction. This is an important one, and anorexia, diarrhea, and vomiting, voice change, abdominal pain. But when we go to grade 3 or 4, only a few of them were occurring at a significantly higher rate than with placebo. And namely, the most relevant are hand-foot skin reaction and diarrhea and weight loss. Fatigue apparently is not so relevant, but when we went into the real life of Italian patients treated with sorafenib, we could confirm that most of the events showed the similar rates to the SHARP trial, apart from fatigue, which was more represented in real life than in the trial. And so what do these findings tell us? Have the patients to suffer uselessly of adverse event to achieve a marginal survival benefit? Well, apparently this is the case, but if we deep into the results, we can see that patients that needed a dose reduction but continued treatment, so they had adverse event, but they did not need to stop the treatment, had a significantly longer survival. Patient who needed a half-an dose lived longer than patient who did not needed a halvening of the dose because they couldn't tolerate well the drugs. This means that this is in the development of adverse events leading to the need to reduce the dose, probably indicates a more effective presence of the drug and leads to longer survival. Therefore, the adverse events are not so negative to be seen negatively because they bring also longer life and they can be easily managed by adjusting the dose. And this was even confirmed by a study by the Barcelona group showing that especially the dermatological events when occurring within the first 6 months are associated with a much longer survival than patients not experiencing these side events. Therefore, these are all clinical significant data to manage patients with adverse event. And on the basis of this data, sorafenib was recommended 10 years ago as the systemic treatment, as the treatment standard of care for patients with advanced stage disease. So therefore, sorafenib was well established as an effective therapy, and we were all expecting that many new kids, many new TKI were on the blocks, ready to become or replace sorafenib, because some of them were even more potent. So we expected to have many more drugs, not only in the advanced stage, but potentially in other settings. However, after these 2 positive trials with sorafenib, the other trials failed those showing that some TKI, even more potent from the androgenic point of view, were inferior to sorafenib. Others failed when they tried to demonstrate the non-inferiority, and others who attempted to provide the superiority to sorafenib failed. as well as when they were combined with endovascular treatment, either radioembolization or endothelial infusion or other chemotherapeutic drugs. Therefore, for 10 years, there was no new TKI showing better results than sorafenib. Why did this happen? Sunitinib had worse survival, probably because the anti-angiogenic potency was too strong for cirrhotic patients. But apparently, the other curves of other drugs like linifanib, brivanib, apparently they or the combination of sorafenib with erlotinib, they were not dissimilar from those of sorafenib. How does this happen? To register a new drug to be non-inferior to the reference standard, you not only need to have a non-statistical significance, but the 95% confidence interval must fall below the 1.08 line. It means that the chance of declaring a non-inferiority is only less than 8% a false declaration. So having this in mind, these trials that had no statistical significance, the results which were not statistically different from sorafenib, actually had a wider confidence interval, which largely crossed the 1.08 border. Therefore, they could not be declared to be non-inferior to sorafenib. Of some of them, like sunitinib, were clearly inferior. This was still 2018, when the results of the lenvatinib versus sorafenib non-inferiority trial were published, and I was happy to be part of this study group, which showed falling with the 90% upper confidence limit below the 1.08 non-inferiority margin, showed that lenvatinib was non-inferior to sorafenib. It had a better progression-free survival, better time to progression, and much better objective response rate. So despite it did not achieve the secondary aim of superiority, it was clearly non-inferior with the trend to superiority. This was probably due to the additional effects of lenvatinib on the fibroblast growth factor receptors, to which it is more potent than sorafenib, and it is also a slightly bit more potent on the anti-angiogenic effect, but not excessively potent. All the subgroup analysis confirmed the non-inferiority. As you can see here on the left-hand side of this dashed line, you can see the data favoring lenvatinib according to the different variables: body weight, performance status, region, sex, alpha-fetoprotein at baseline. And indeed, the progression-free survival was better with lenvatinib than with sorafenib. And this was confirmed also in the subgroup analysis, showing even better results than the overall survival data. And this also led to a longer time to progression. So the data were confirmed from all points of view. Which were the adverse events that you have to pay when you have these results? They are not that worse than with sorafenib. Only hypertension is significantly occurring at a higher rate, and proteinuria than with sorafenib. And this is not something that affects the symptom of the patient. This is more a finding that is covered by the physician, but probably beneficial for the patients. There is a lower rate of palmar plantar erythrodysesthesia. So overall, the quality of the adverse event is similar to sorafenib, but the entirety, the severity is slightly different. So is there any role for TKI beyond the advanced stage? We will be happy to have additional applications of TKI. These were tested as adjuvant after resection of ablation. This was a phase 3 randomized trial. However, the superiority of sorafenib was totally not demonstrated. The course of recurrence-free survival was almost identical. Therefore, there is no role of TKI apparently to improve the survival, the recurrence rate after resection. So maybe there is a benefit when combining with endovascular treatment. This is a negative trial, but also in combination with TACE, there is no benefit in patient in the intermediate stage when adding sorafenib, not in terms of time to progression and not in terms of overall survival. And this was the case also when combining not with transarterial chemoembolization, but with internal radiation therapy with yttrium-90. Therefore, unfortunately, there is no role at present of TKI in combination with local regional treatment or with surgery. After the first line in the advanced stage, is there a role for TKI in second line? Until a few years ago, there have been a number of failures. Various TKI like brivanib or other drugs like tivantinib, adipeg, monoclonal antibodies like ramucirumab in overall patients. There is trial, mTOR inhibitor, everolimus, all of them failed to be superior to placebo. Therefore, we were all quite disappointed until 5 years ago. At that time, there was the arrival of a phase 2 and then phase 3 trial with regorafenib. Actually, initially, we were not so much convinced that there could be any benefit because, as you can see, chemically, the two molecules, sorafenib and regorafenib, are almost identical. There is only these fluor molecules, atom, positioned in the molecule, which makes the two molecules different. Nonetheless, the phase 2 trial was favorable, and therefore the molecule, the agent, was moved to a phase 3 trial randomized to placebo. Interestingly, the time interval allowed between sorafenib stop and randomization was only less than 10 weeks. This was implemented to avoid the enrollment of patients with slow disease because they were waiting the trial to arrive, and this could bias the results. So these are the true results, what you do in real life when a patient is progressing on sorafenib and is tolerating sorafenib. So patients were randomized, and the survival course clearly demonstrated a benefit of regorafenib over placebo. And also in this case, the gain, the magnitude of gain was about 36% improvement in survival for patients receiving regorafenib TKI compared to placebo. So we were having in 2017 the first effective second-line therapy, which was a TKI. Also, in this case, like in first line, the benefit was due to advantage in progression-free survival in patients tolerating but progressing on sorafenib. Cabozantinib is another TKI. This was also tested. The difference to the other trial was the patient had to be either progressive to sorafenib, progressors under sorafenib, or intolerant to sorafenib, as the mechanism of action is different from sorafenib. But patients who could have received also another line of therapy beyond sorafenib. So some of the patients were in third line. Patients were randomized 2-to-1. The stratification factors were the common ones. And also in this case, cabozantinib demonstrated an improvement in survival compared to placebo. The trial was run at a similar time when the trial with regorafenib was run. Therefore, even at that time of this trial, the reference standard of treatment for second line was placebo because there was no effective therapy. The hazard ratio was similar, slightly higher than that of regorafenib, but also in this case, the trial was successful, and regorafenib is now a treatment for further lines after sorafenib failure. Interestingly, as I mentioned, a number of these patients was in third line, Obviously, the number of these patients is very limited, so this is only an exploratory analysis. We cannot draw any conclusion about the benefit of cabozantinib in third line. You can see that the 90% confidence interval largely cross the one line, so it is still unclear whether we have a really effective third-line therapy or not, but we can use cabozantinib even third line. So this is a potential benefit of having this TKI. Actually, there are other drugs. This is a monoclonal antibody that failed in the all-comers advanced HCC in second line compared with placebo, but when analyzing in a subsequent trial, the REACH2, only patients with high alpha-fetoprotein, a survival benefit was evident, with similar survival improvement of the other trials. The ratio is 0.68, similar to regorafenib, but this drug is to be administered intravenously, so is a little less convenient and is not being adopted, at least in Europe. So, trying to draw some conclusions and make some thoughts about the use of first-line TKI at present. Before going to the conclusion, we have to consider these new findings. This is the comparison of pembrolizumab, an immunocheckpoint inhibitor with the TKI lenvatinib, versus lenvatinib alone, presented last year at the ESMO Congress. Patients were randomized 1-to-1 of the combination of TKI and immunocheckpoint inhibitors versus a TKI alone. I don't go into the details of the trial. Almost 800 patients were randomized. And when we go and look at the survival, I'm not mentioning, not discussing the comparison, but I'm only looking at the results of the TKI. You can see that we have a survival rate of 40% at 2 years. So this leads to a 19 months of overall survival, which is largely superior to the 13.5 months shown in the REFLECT trial, the phase 3 trial of lenvatinib. This has to stimulate our thoughts about the use of TKI in first line. How could this happen? First of all, there was a survival improvement also with sorafenib over time. So we might have passed this learning curve for survival. This is, I'm not going to detail why this the trial failed in terms of the primary aim, but I only would like to point out the results of lenvatinib. You can see that in this trial, lenvatinib confirmed to have a high objective response rate, a very high disease control, 83% overall. So the effect of the 19 months is due to a very good effect of TKI in first line. This is a high number of respondents to lenvatinib, and potentially about slightly more than 1/5 of the patient could receive a immunotherapy in second line after lenvatinib. This led to 19 months of survival, which is really high for a TKI, and leads to some thoughts. So, which is the current situation? When TKI may be advantageous at present in first line, in very fragile patients or patients who has conditions that may be prone to adverse events, when we use the combinations of immunocheckpoint inhibitors and anti-angiogenic monoclonal antibodies, leading to the forecast of better tolerance and therefore more effectiveness of TKI. This is especially true in patients with a history of cardiac failure, cardiac valvular disease, previous hemorrhagic stroke, previous serious embolism, need of full anticoagulation, severe psoriasis. These are all conditions which are relative contraindications to, or sometimes absolute contraindication, depending on the severity of monoclonal anti-angiogenic monoclonal antibodies against vascular endothelial factor. And in these situations, also TKI are partially contraindicated, but we can modulate the treatment differently from the intravenous drugs. We can start with lower doses, see how they are tolerated, and upgrade the level of treatment. This is why potentially TKI have still a role in difficult patients, because they do not only have the possibility of a fine modulation of the daily doses, but they also have a shorter half-life. Therefore, if there are complications like bleeding, anemia, we can easily stop the effect of the drugs within at latest a couple of days. We don't have to wait a couple of weeks. Moreover, as I've shown, potentially the data of a first-line TKI might become advantageous if the sequencing with immunocheckpoint inhibitor in second line could be allowed. This is not the case at present, at least in many countries worldwide. Therefore, the competition with immunocheckpoint inhibitors is still tough, but the data of lenvatinib are very appealing in terms of sequencing. So, to conclude, when to use TKI? Always when immunocheckpoint inhibitors are contraindicated, and also TKI obviously are not totally contraindicated. Possibly when TKI, which do not show so much worse outcome compared to immunocheckpoint inhibitors, are preferred by patients because there is no need for regular access to the hospitals. The pills can be taken at home, or in fragile patients at risk of severe events when using immunocheckpoint inhibitors or pure anti-angiogenic drugs. Or the physician might prefer the TKI, potentially, if there is a request for evidence-based sequencing upfront, not only the most effective first line, because we don't know what to give after immunocheckpoint inhibitors, but we know what to give after sorafenib, because there is evidence of drugs working at least in second line and potentially in third line when we start with sorafenib. So there is a more evidence-based, there is a stronger evidence behind the sequencing. And the TKI remain a possibility, a quite common possibility to be utilized in third line. This view is also endorsed by the new updated BCLC view, which use sorafenib or lenvatinib when the immunocheckpoint inhibitors is not feasible or contraindicated, together with bevacizumab, for instance, or pure immunocheckpoint inhibitors, or in second line after sorafenib, the strongest evidence for sequencing, or in third line. Having said that, I think there is still a role for TKI in all the different situations of first line, second line, and third line. Therefore, I thank you for your attention, and all of you who are interested in liver ultrasound are invited to the European meeting on ultrasound, the Eurosound 2024, in Naples, 1 year from now, November 2024. Thank you very much for your attention.
Is Shiv-Sarin around? Moderator, Shiv-Sarin.
Yeah, Professor Masao, yeah.
Oh, she's gone.
Yeah.
Dr. Sarin is not here.
No, you have to.
Right, Ashok. So he's gone then. I think this is Dr. Omata from Japan. How are you? Happy or Fiscari? Thank you very much. A little bit late, but wonderful talk. So may I question a couple things and invite like Dr. George Lau. He is being involved in for many trials. So George, do you have any questions about or comments?
Well, this is excellent talk. Actually, we have two very distinguished speakers tonight. I think that the problem is in the real world, after the first line, you have to go for a second line, and for patients who have a cellular carcinoma, there is nobody really knows what to do next after the second line, or when are we going to switch? In terms of when are we going to, whatever first lines it takes, when would one decide to switch to another form of therapy? Do you treat beyond disease progressions, for instance? How are you going to define this? And what are our positions at this moment? What are we going to do with so many molecules of drugs available? how are we going to make a decisions of first when to switch, when we would like to define in terms of ICIs or the TKI or the combinations, and I would like to hear from all of you.
Well, Fabio first, anyhow.
Okay, thank you. Good morning, everybody. Sorry I was late, but I was traveling back from a congress. So actually, this is a very difficult question, and there is no definitive answer. And it depends also on the local prescription possibilities, which is quite variable worldwide. And in my view, it would be the best choice would be to change the mechanism of action, or to combine two different mechanisms of action. It also depends on the timing of the progression. If the progression occurs in first line after immunocheckpoint inhibitors at an early time point, let's say 2 months or 4 months, we usually definitively stop, because this seems to be primary refractoriness, and there is no advantage if pseudo progression has been ruled out to continue with these drugs, at least with the same drug. So in this case, we switch to another molecule. If instead the progression is very delayed and minimal, in terms only of no new lesions, only size progression, but occurring after 1 year, 1 year and a half, we may decide together with the patient to continue, at least for one more term, one more cycle, to decide whether something has really changed and now the tumor is going to grow fast, or if it has been slowed down by the treatment despite not being arrested in its growth. In this case, given the lack of alternatives, we might continue, also depending on the local rules, if you're allowed to continue or not.
Well, Dr. Hang, do you have a comment? May I have your comment or question? Yes, Dr. Han, please.
Yes, I think for the IO era, so it's some person may experience a pseudo progression. So in that case, I think treatment beyond progression can be considered. For example, if we made a patient imaging progression, but in clinically the general condition still quite well, and the tumor marker, including the alpha beta protein and the PICA2 still going down. In that case, I think I will try to keep the immunotherapy, because those patients may have a chance of a pseudo progression. So I will keep an additional 1 or 2 sections of immunotherapy. So let's say for immunotherapy, but for the TKI, I won't do the treatment beyond progression, because if the imagery confirm the progression, I will switch it, because currently we have many TKI in our hands and many second line and third line choice. So in that case, I will switch my treatment. Thank you.
Well, thank you very much, Dr. Han. I mean,
yes, may I just one comment?
All right.
I forgot to mention one other point which drives the possible decision. When I was talking, I was always thinking a patient with perfectly compensated chronic liver disease, Child-Pugh A5. If during treatment the patient has moved to Child-Pugh A6, then sometimes we would like to anticipate the switch, offering an alternative possibility to test a new drug, because sometimes even if the tumor has slowed down, but you wait a couple of months or 4 months, maybe at the next time of re-imaging, when you demonstrate progression, the patient has progressed to B7, and then maybe you have lost the opportunity to give an alternative treatment. So even liver function is a very relevant role, and it has been strictly monitored. We don't have to wait for decompensation, but look at how the liver function is reacting.
All right, thank you, Dr. Fabio. Before your meeting in November next year, we have a meeting in Kyoto, March, the end of the Kyoto APASL general meeting, so we can continue this discussion. Thank you very much.
Okay.
Yes. All right.
Bye-bye.
Bye-bye. Then George Lau, could you moderate the last session, grand rounds, please?
Sure. Yes. Well, it's my pleasure. I'm George Lau from Hong Kong, China, to moderate the case discussions. May I have the case presented? Who is going to present the case? Also, is this you or Dr. Mark?
Yeah, Dr. Mark is going
Yes,
to.
I remember. Yes, Dr. Mark, could you please put up the case?
Sure. Yeah. Hi, can everybody see my screen?
Yeah, it is.
Okay, good. Sorry, I'll just a bit. Yeah, hi. So firstly, I'd like to thank the organizers of ALCAP and for inviting me to present our case in the grand rounds. So I'm Mark. I'm one of the liver transplant physicians from the National University Hospital in Singapore. So I think I'll go straight into the case. Our case today is about a 59-year-old Chinese gentleman from Singapore. So he works as a tour guide, meaning he travels quite often, and he's married with two children. He has no family history of liver disease, liver cancer, or psychiatric issues. And his father has had lung cancer. He personally stopped smoking during his national service or his army service in Singapore, which is usually done when people are about 20 years old. And he's not a drinker because he gets rashes and turns red when he drinks. And he has hyperlipidemia on diet control. So I think his original presentation was because he was referred for asymptomatic raised liver enzymes. And he was seeing his primary care physician for 6 years. And the primary care physician had done an ultrasound of the liver that showed that the liver was diffusely echogenic in keeping with fatty change. And he was being given vitamin E with no improvement in his liver enzymes. He added on ginseng, which is a common supplement taken by some of our patients, to his weekly routine, and he had no other traditional or herbal medication. So on examination, when he was seen in our center, he was otherwise well, nothing abnormal except for a body mass index of 25.2, which is overweight according to the Asian cutoffs, but no stigmata of chronic liver disease, no hepatomegaly, no splenomegaly, So these were his investigations that were done. So we can see his liver enzymes were raised at 216 and 154, ALT and EST, but ALK phos, BIL, albumin were all normal. Platelet count was 194. But interestingly, his IgG was 20. Our upper limit then was 15. His ANA was 1:80, and his anti-smooth muscle was 21, which is indeterminate in our lab. LKM and SLA were negative, ceruloplasmin was normal, Hep B, Hep C, all the viral markers were negative, and his fasting glucose was 5.9. Again, a repeat ultrasound showed a fatty liver with a normal spleen and no focal hepatic lesions. So what happens is that this gentleman had a fibroscan. This was done actually before we had the machine with the CAP score. So the fibroscan score was 16.3 kilopascals. And given his raised, and there was a question of the possibility of autoimmune hepatitis or NASH, and he had a liver biopsy done. So I've put some of the liver biopsy slides here. So you can see here that he has steatosis with balloon hepatocytes, alluding to NASH. However, and so you can see here, my pathologist has pulled out some of the pictures for me, a balloon hepatocyte with Mallory dank bodies. But what was very interesting was that he also had portal inflammation with mild interface activity. So, and our pathologist just couldn't let go of the interface activity and said it was real. And also importantly, there were clusters of plasma cells all around. So very interesting that this patient, and the other thing is this patient was cirrhotic with nodule formation, and he has periportal and pericellular fibrosis. So this is quite clear on the Mason trichrome stain that we can see this. So in summary, he probably has NASH, which is driving the bulk of the disease, or MASH, or what metabolic associated steatohepatitis. But what is important is he also has an overlap with possible autoimmune hepatitis. So we know that there is metabolic dysfunction steatohepatitis, and we also know that there's autoimmune hepatitis. So again, this was our discussion at our pathology meeting. So now, if you look, when we look at the autoimmune hepatitis scoring, using both the standard and the revised scoring, they've actually changed this, because when I looked at his notes from back in 2018 when he presented, it actually said definite AIH or definite autoimmune hepatitis, but now it says likely autoimmune hepatitis. But the score is still the same, 7 points and 14 points, meaning this was likely to be autoimmune hepatitis. So what happened is we started treating him with immunosuppression. So with prednisolone 30 milligrams and azathioprine 50 milligrams. And he had a slight reduction in the IgG and a reduction in the liver enzymes, but no clear normalization of his liver enzymes. So before everyone gets upset with me and says this is a liver cancer grand rounds, please hold on, because we'll come to the reason why we are presenting this case later. So, and overall, and given his difficulty in achieving a normal liver enzymes, he was started on vitamin E. So his progress was basically he had a fluctuating course with multiple failures at attempts to minimize steroids in keeping with an immune condition. However, vitamin E also appeared to help with his liver enzymes. And his IgG was eventually controlled, but we had challenges with achieving a normal ALT and EST. Of course, there were calls for repeat biopsy, as what we'd have done if managing this as per autoimmune hepatitis. And we also monitored him as for cirrhosis, meaning 6 monthly cancer markers, as well as imaging of the liver. Along the way, probably because of the steroids, he developed diabetes and hypertension as well. He was serially followed up. So 5 years later, he presents with fibrosis. The ultrasound shows a hypoechoic foci measuring up to 1.1 centimeters and recommended for further multiphasic imaging. So this was when he was compliant. However, as I mentioned, he travels quite often, and so he missed his follow-up and came back 9 months later instead of 6 months later. And surprisingly, his alpha-fetoprotein had jumped from 10 to 24,200. And the MRI liver showed a large arterially enhancing area in the right hepatic lobe infiltrating segments 5 and 8, with foci of washout seen and with tumor invasion of the right anterior portal vein. And so, and of course, the suggestion was that this was liver cancer. So I've put some of the slides, including the arterial enhancement in the arterial phase enhancement in the middle, and the washout on the right. So you can see that this is a segment 5, and I'm unable to scroll, so I've just given the best picture that I could find of the segment 5-8 tumor, but the maximum diameter was 11.2 centimeters. Now, sadly, he also had a CT thorax done at staging, which also showed that he had multiple 1 to 2 millimeter lung nodules scattered in both lungs. So these were suspicious for metastatic disease in the lungs. There were no bony lesions, but our final diagnosis was metastatic HCC with portal vein invasion with 11.2 cm tumor. So I think the first question to have everybody think about is this is a patient with likely autoimmune hepatitis or a component of autoimmune hepatitis, and he's a candidate for systemic treatment. And I guess the clinical dilemma are immune checkpoint inhibitors a consideration. So I've just put this phrase here that came out from IM Brave 050 that basically shows that among the key exclusion criteria was the history of autoimmune disease. So initially, the oncologist was not keen for immune checkpoint inhibitors. However, our team has known the patient for a very long time. We are following him up for 6 years thus far. And he was quite young, still about 50 plus. And he really wanted the best shot, and he wanted to know all the survival outcomes. Now, he presented just after the Himalaya study data came out, and he's of course quite well-versed, and he has looked through all the literature himself. So he was very keen to attempt immune checkpoint inhibitors given the best outcomes that they have seen, and not from and he felt that a TKI or a sorafenib, which was offered to him, was inferior compared for first-line immune checkpoint inhibitors. So after discussion, Durva-Tremi or the STRIDE regimen was not an option given the high-risk immunology, and the oncologists were agreeable to proceed with close monitoring by our hepatology team. So we weaned his steroids for optimization of immune checkpoint inhibitor response. So the patient was given atezo-bev, initially tolerated well. However, after 2 cycles, he presented with sudden onset of abdominal distension, worsening jaundice, and functional decline. So his presentation, abdominal shortness of breath, loss of appetite, lethargy, and his weight gained from 63.8 to 74 kilograms since cycle 1. So a 10 kilogram gain in weight. On examination, he was alert, lethargic, poor inspiratory effort, no hepatic flap, and tense ascites. Now, sometimes although we don't have a hepatic flap, sometimes we chart the on plus off time from the Stroop and Cephalab that has been published by Jasmohan Bajaj. And so our on plus off time was really quite high at 248 seconds. This is a gentleman who was previously working alert and well. So our investigations did show that he had an albumin of 26, bilirubin of 50, which had jumped from normal before, and AST of 506, which had also jumped from before, and an LDH of 617. Now, interestingly, his INR also has shot up from 1.02 to 1.71 on presentation. His blood count was otherwise normal and renal panel was normal. An acidic test was done that showed a fluid protein of 13.6, a high SAR. So if you can see, your albumin is 6, and serum is 26, so SAAG is 20. Fluid protein was 13.6, and predominantly lymphocytic, but no evidence of infection in the acidic count. And the IgG had jumped to 27.6 with an ANA of 1:80 and an anti-smooth muscle of 59. So the original impression by the oncology team was that of a progression of HCC causing severe liver impairment. So it was referred to the palliative team because they felt that he had failed on checkpoint inhibitors. He was too deconditioned to continue with any further chemotherapy regimens, and they felt he was quite unwell. I think if you calculated his trial score, he was a 9. His trial score was 9 at that point in time. So they basically said end of life care protocols to be instituted. And this is the last point I put in. They conducted, his daughter was about to get married. And so when we conduct tea ceremonies in the hospital, so a tea ceremony in our Asian culture, especially in our Chinese culture, in our local population, is a very important part of the wedding. And to bring the tea ceremony forward means that we really expect the patient to pass away in the near future. So the tea ceremony for his daughter's wedding was conducted in the hospital room. So I think here we'll just, I just put some slides on hepatotoxicity from checkpoint inhibitors. And basically, he met grade 3 checkpoint inhibitor toxicity, but not discounting the significant worsening of liver function. So our opinion was that he had severe checkpoint inhibitor hepatitis or liver dysfunction, more than just hepatitis. Grade 3, according to the CTCAE, however, his significant liver impairment with new onset ascites, coagulopathy, and jaundice alluded to a significant liver impairment, and potentially even, with the worsening of the on plus off time on the Stroop and Cephalab may be quite significant. And so initially, we tried to push for initiation of steroids. However, the palliative team was keen to reduce pill burden because they felt that he was his end of his life. Finally, even though he was a cirrhotic patient, so in general, we don't start budesonide for cirrhotic patients. We started him on budesonide 9 milligrams. The reason being because if we were to start him on high-dose steroids, then we'll have to give prophylactic medications, Bactrim, and that would increase the pill burden. So it's an argument to reduce the pill burden. So the patient was terminally discharged to home hospice in view of the opinion of progressive HCC, intolerant to systemic treatment, and he was discharged in a wheelchair. So 1 month later, he walks into the clinic as per normal after the budesonide. He's still on the budesonide. No more ascites. Weight has come back to 64 kilograms, back to baseline. And he actually, just before the clinic, traveled to Thailand for his daughter's wedding. And he was compliant to his budesonide. So this is the trend of his liver enzymes after starting the budesonide. We can see a reduction in the liver enzymes and the INR as well. Now, I've just put it, these are week 2, week 4, week 6, and week 8. And so quite a rapid improvement over 2 months. But what was very interesting also, this AFP is not actually on admission, but prior to initiation. of the checkpoint inhibitors, or the 2 cycles of atezo-bev that he got. We can see by week 2, the AFP had come down significantly to 4,300. So this was at a diagnosis of 24,000. And by week 8, it had come down to 11.3. Now, a repeat CT thorax was done, which actually showed no further lung nodules no further nodules in the lungs. And however, the densities corresponding to the tumor could be seen, but it was smaller than before. Now, I've put the MRI scans from 3 months post checkpoint inhibitor and 9 months post checkpoint inhibitor. So you can see that the disease is actually shrinking, and there's some capsular retraction at the side. And really, by the time we did the 9-month scan, they were not sure, our tumor board was not too clear whether this was truly disease left in the liver, or was this just a scar reaction from the shrinkage of the tumor. So they say there's equivocal arterial enhancement with delayed washout. So given this, because they were not sure whether there was disease, a dual tracer PET was undertaken, because that was going to, because there were discussions whether he may be a candidate for resection or further more aggressive treatments. So you can see on the left side, we have acetate PET, and on the right side, we have an FDG PET. But basically, the liver is cirrhotic with fatty change, and the lesions did not show increased tracer uptake compared to the background liver activity. So currently, his follow-up, his budesonide has been tapered to 3 milligrams. His liver enzymes are stable at 1 to 1.5 times upper limit normal. He was offered an angio-KIV test. Why an angio? So that we could look to see whether there was any enhancement characteristics on the angiogram, or selective beam radiotherapy, but the patient declined because he feels so well and he does not want to push things any further. So he's currently on monitoring. He's more than a year after his initial presentation, and the discussion with him and the family is for a re-challenge, or a potential re-challenge of his immune checkpoint inhibitor in event of disease progression. However, the family have asked whether transplantation is a consideration if there has been significant improvement or downstaging of the disease. So I think to end my, I've brought up some discussion points that we can take from this case. So I guess the first discussion case is we'll talk about, we can consider the discussing the use of immune checkpoint inhibitor regimens in patients with autoimmune hepatitis, or patients like this who have NASH or some other disease with some autoimmune overlap, re-challenging checkpoint inhibitors in patients with ICI toxicity. And what is the latest literature on this? Differentiating the causes of raised liver enzymes in ICI-treated patients, management, and of course budesonide. If we have time, I know Ashok knows me. I am a liver transplant hepatologist. I would sneak in a line on transplant there, but we can, if we don't have time, we don't need to discuss point 6. So with that, I would like to open up the floor to all our esteemed experts here. Thank you.
Yeah, very interesting case. Very, very interesting case. And thank you for your excellent presentation. I might miss the point. Do you have a biopsy for your hepatocellular carcinoma? Before
we don't. Yeah, so we don't have, because the atezo-bev is already approved in Singapore. And so if it was conducted under a clinical trial, the patient would have had a biopsy. So I think Pierce was conducting the trial. There were some biopsies done, but however, after that, this is a clinical indication. And the radiologist felt that this was a clear-cut diagnosis of hepatocellular carcinoma, especially with the enhancement characteristics on the initial MR imaging.
Because I really think this is a very atypical presentations, and it would be of great interest to really have a histology and how this could have response in such a manner. And my second question is, do you have MRI or surveillance on this patient, since you have been following up this patient for 6 years with Marfan, and you mentioned about the alpha fetoprotein on emissions. It's 20 to 30,000 at that range. So
Yeah.
yeah,
So
you have a prior MRI to
No.
show that. No, okay. So you just ultrasound before
Yes.
he come to you with very high alpha fetoprotein and also this list of symptoms. That's
He was
after.
stable. He was a
That's after
stable.
mhm.
He was a stable cirrhotic with a normal alpha fetoprotein of 10 or less than 10 for about 5 years. And then when he suddenly presented, and he actually missed his follow-up. So he developed the previous ultrasound had a 1.1 centimeter hypoechoic lesion. So it was actually supposed to go for an early MRI, but this was missed for about 9 months before he came in again, and then there was the jump in the alpha fetoprotein and the very large lesion with the metastatic deposits.
That's a very interesting case. Lots of questions. I look forward to see if you could have a further surgical measure on these patients to understand the pathology of the lesions. Because first, it's really grows very rapidly with this hepatocellular carcinoma. And secondly, the response is really amazing with if it is hepatocellular carcinoma. And I understand, appreciates the previous liver biopsy, which also is interesting. It shows fatty changes, but also the plasma cell infiltrating in the portotriate. So it's a typical case, very atypical. And in fact, you don't expect him to survive after all. Yes, it's amazing. But after all, being doctors, we all like to see patients live happily and with a good survival. So that's my comments. Any other comments from the floor?
Omata from Japan. I have a couple questions and comments. It's an unusual case. It's amazing. You know, I'm being in this field 53 years. And then 6 years, I was in the pathology department. I saw maybe 3,000 cases of the liver biopsy in the 40-some years ago. And then that particular biopsy was done. How many years before you discovered the elevation of AFP?
About 5 years, 5 to 6 years, 5 to 6 years.
There is a long time in between, because you know the first biopsy shows a fatty change certainly, and some ballooning, and then you said Mallory bodies, but it's not really typical Mallory bodies in the old classical types, but it looks like. And it's not, there is no bridges or the fibrosis. So maybe it's not a completed cirrhosis. It's a suggestive cirrhosis, but extent of the fibrosis is not in the range of the you expect develop the cancer. So that case is quite unusual. And at the end, the current problem is whether you should do the transplantation or not. But I recommend from my experience on hepatocellular carcinoma, after that, so maybe 35 years, why don't you do the lectin binding protein assays, L3? Because AFP is now flat, almost flat. But sometimes L3 helps because maybe the patient is really worrying about the recurrences anyhow. That's why you are talking about the transplantation. So maybe just a simple technique, take blood, measure the L3, despite LP down to 10 nanograms. Sometimes L3 can be as high as 15%, which might be indicative of the cancers or remnant by cancer somewhere in the body. That may help. So I think at this moment, I suggest take the blood and check that one. But otherwise, I don't have any good ideas of whether there is a tiny bit of the tumors remnants, not just in the liver, but in other parts. And that's a worrisome futures, right? So that's the questions. And for that, I cannot suggest because this is so unusual and in a sense so happy. So, but how to maintain this happiness is a big, big challenge for us. So that's my question. But the great cases. I've been in this field for 53 years, but this is one of the wonderful cases. I really applaud you. Wonderful.
Thank you. Thank you, Prof. I think that's very useful. I think to put some background, he would never be a transplant candidate in Singapore because he was metastatic disease at presentation. And I think from a legislation standpoint, we can't. I put it up here for discussion, but yes, the comment about AFP L3 is very valuable. When Ashok asked me to present a case, he asked for an interesting case. So I felt this was one of the most interesting cases that we've seen, so I selected it. I've actually I've prepared just some possible literature to help us in our discussion on the points. Maybe I'll move.
Mark, sorry, Marceli, why you have given this budesonide?
So why we gave budesonide was we actually wanted to give steroids because we felt that this was related to the immune checkpoint inhibitor. However, there was a bit of difference in opinion between our team, and the palliative team felt that because when you give steroids and you're going to give you're going to give the steroids for more than 4 weeks, you need to give your PCP prophylaxis, which may be Bactrim. You may need to give nystatin to the patient, and they felt this would increase the pill burden. So we used budesonide. In fact, I've prepared some of this literature for checkpoint hepatitis. There's actually a study, not so much in liver cancer, but in lung cancer, that has reported the use of budesonide or liver-directed topical steroids that has helped with resolution of the checkpoint hepatitis. We actually do use this in the checkpoint hepatitis we see with renal, and because renal is usually in combination with a TKI, as well as in lung checkpoint induced hepatitis from lung cancers. And it's shown to our experience is it's worked quite well. So we used it as a strategy because we really felt that he would benefit from some steroids given his acute deterioration.
Yeah, so nice. Another important introduction, Mark, this patient responded dramatically to the Atelier and Bevacizumab, but we have to stop because of this injury. But what is the way forward? Would you like to give him TKI, or you are not going to give any treatment?
Okay, so this has been actually discussed quite extensively. For me, I mean, my view as part of his managing team was that, he responded really well. I think for some of the patients we've seen on Atezo-Bev, and I think both Prof. Lau and Prof. Huang have been involved in some of the studies and may have a greater experience than myself on this. But we actually do see some patients who get a few doses and respond quite well in the initial setting. And of course, a lot of these patients, because of the protocol, they carry on getting the Atezo-Bev. This patient held it off. Now, the question is, what is the risk of recurrence of the liver injury or the liver damage? If we look at ESMO, I've just summarized ESMO, ESCO, and AGA guidelines here. And all of them would say hold ICIs permanently, immune checkpoint inhibitors permanently, which would be ESMO, ESCO, and AGA. However, earlier this year, there was this multi-center study that came out. If I'm not wrong, the senior author was Maria Buti, that published in CGH on grade 3 and grade 4 toxicity within the liver with immune checkpoint inhibitors, and they re-challenged. So they had 23 patients. So if you can see, 8 patients had recurrence of the liver toxicity, and 15 patients actually did not, even though it was grade 3 or grade 4 toxicity. 15 patients did not have recurrence of the toxicity. And of the 8 patients who recurred, only 3 ended up stopping the checkpoint inhibitors early. So this alludes to the fact that we can potentially re-challenge these patients, but we have to be very cautious and prepared to salvage them. And what is very interesting in this study is that all the patients who were re-challenged, eventually the thing that caused their mortality was not an immune-related event, but actually disease progression. So I think we must remember that we're dealing with someone. So I think the risk that we potentially may take may be higher, but this space is coming up with a lot of evidence in terms of re-challenging these patients with checkpoint inhibitors.
May I comment, George? May I comment, Dr. Mata? Ashok,
please go ahead.
Yeah. Well, first of all, about liver biopsies, you mentioned the plasma cells there, but I think it's not impressive. So you are you shouldn't take too much about the plasma cell infiltrate. So I think this is simply fatty change with some ballooning, and maybe due to NASH, not really autoimmune type. And the second about this G3, G4 toxicity, liver injuries, IRAE, I think they should consult the hepatologist because G3, G4 grading is based upon the ALT elevations. But we hepatologists know not just a simple elevation of up to say 1,000, 2,000, it doesn't matter. Prothrombin is a key. So, I mean, they stop it. But it's quite unfortunate. Our data shows that if there is a IRAE or liver injuries, they stop it, but end up shorter lifespans. In other words, those are the people who may survive if we go through the liver injury, so-called. So we should maybe can play a very important role about the judgment to stop, not to stop. And then our hospital has almost 1,000 cases of IO experiences. Majority of the cases are not consulted to me, Omata. So I'm complaining about pulmonary people or the renal people. Why don't you come to me? I'll explain, you are okay. And then you are talking about now re-challenging. But most of the people just surprised and astonished by the elevation of the ALT more than 1,000. But Ashok and Shivsarin and George Rao knows about. So I think impending hepatic failure and also elevation ALT is a different matters. So I think this may also indicate that. So for the patient's sake, that's my comments. Sorry about
yes.
I spoke
yes,
too much,
Prof.
but it's so exciting.
I fully agree with you, Prof. Because if you look at all the onco guidelines and CTCAE, a bilirubin elevation of 5 times is treated the same as a ALT elevation of 5 times.
Right.
So really, I think for us, a bilirubin and an ALT elevation of 5 times is very different. Yeah.
Exactly. Most of the cases I judge in my hospital, bilirubin is not elevated at all. But ALT is putting too much emphasis on the elevation of the ALT. But don't worry about it, that's my message.
Yes, I agree, Prof.
This is a very important point. Totally concur with Professor Omata. I think that you have done excellent jobs and a very interesting, very interesting case. And I really look forward to hear what happens to these patients in the very near future when we come in touch with you. Well, because of the time issues, I think that's is a good evening, and we have to round up here. Any final comments from Professor Omata or the Ashok?
No. Exciting choice of the case is amazing. I'm excited. I mean, I've been in this field for 53 years, but this is amazing. But the patient's still young, and he wants to have a long life, not just attending the daughter's wedding. He's expecting more. So maybe we can now, in the time, to make him happy. But I'm very happy to hear all this discussion. Thank you, George, and so thank you, Ashok.
Thank you very much.
Yeah,
maybe bring him to Kyoto. Let him come to Japan.
All right.
Thank you very much.
Good.
Okay.
Thank you.
Okay.
Bye.
Good
Thank
night.
you.
Good night.
Good night.
Good night.
Good night.
Bye bye. Ashok, bye bye.
Yeah. Bye.
Bye.
Yeah.
Bye.